Hey, welcome to The Explainer. Today, we're diving into a lab finding that pops up all the time, but can have some really serious implications: hypercalcemia. We're going to break it down from a pharmacist's point of view, really zeroing in on where your expertise in patient care and counseling matters most.
Okay, so let's picture this scenario. It happens all the time, right? Whether you're reviewing supplements in a community pharmacy or combing through a complex med list in a hospital. Getting a handle on the what, why, and how of high calcium is absolutely vital. So this explainer is all about sharpening your skills and boosting your confidence when you're talking to patients and other providers about it.
So here's our game plan. We're going to tackle this in 5 parts. First, we'll frame our unique role as pharmacists. Then, we'll get into the diagnostic side of things. After that, we'll cover the foundational first-line therapy, then the specific meds, and we'll wrap up with the most important takeaways for your practice.
All right, first up, let's start with the big picture. Why is this so critical for us as pharmacists? Well, it's about being way more than just a dispenser of medicine. It's about being a clinical detective.
And this is really the crux of it. See, a lot of cases of high calcium are mild. They develop slowly, and the patient doesn't even feel it. But a fast increase, that can be the very first sign of something much more serious, like cancer. Your vigilance, your review of a patient's history in labs, that's what helps catch these huge red flags early on.
So how do we figure out what's actually causing it? To treat this effectively, you have to know what's driving it in the first place. The good news is the diagnostic workup is actually pretty logical.
This whole diagnostic puzzle often comes down to just 2 things. How long has this been going on, and what's their parathyroid hormone, or PTH level, doing? So if it's a chronic issue and the PTH is high, you're almost certainly looking at hyperparathyroidism. But if it came on suddenly and the PTH is low, that is a major red flag for malignancy.
And that simple clue is so powerful because those 2 conditions, hyperparathyroidism and malignancy, account for a whopping 90% of all cases. 90%. So just by understanding that, you can focus your clinical brainpower on the scenarios you're most likely to see.
Okay, let's switch gears to treatment, starting with the foundational stuff. These are those crucial first-line moves where your counseling can make a massive difference, sometimes before a single prescription is even written.
Think of this as a 4-point action plan. First, you want to encourage patients to stay mobile because that helps keep calcium in the bones where it belongs. Second, you got to review their intake of calcium and vitamin D supplements. That's a big one. And third, of course, is a thorough med review to stop any drugs that could be making things worse, and that is squarely in our wheelhouse. And finally, the most important one, hydration. This is where your counseling becomes so important. For a patient with mild to moderate hypercalcemia, you need to drive home the importance of hydration. The goal is about 3 liters of non-caffeinated fluids a day. And you have to explain the why. It helps the kidneys do their job and literally flush out that extra calcium. Now, in severe cases in the hospital, this is done with IV saline, but the principle is exactly the same.
Okay, let's talk about a huge clinical pitfall here, a common misconception that can really get you into trouble. You might think, hey, a loop diuretic will help get rid of calcium, but it is often the absolute wrong move. Unless a patient is clearly fluid overloaded after they've been fully rehydrated, loop diuretics can actually make things worse by causing more dehydration. This is a critical counseling point, especially when talking with prescribers.
All right, now let's get into the pharmacologic toolkit, the specific drugs used to manage hypercalcemia. Understanding the little details of these agents is what makes your counsel so effective.
For hypercalcemia of malignancy, IV bisphosphonates are a cornerstone of therapy. And when you're comparing the 2 most common ones, zoledronic acid is pretty much the winner. It's not just more effective, its infusion time is a total game changer. We're talking 15 minutes versus 2 to 4 hours for pamidronate. That's a huge practical advantage for everyone involved.
Now, what about denosumab? Well, think of this as your go-to alternative, especially for patients with really poor kidney function. Since it's not cleared by the kidneys, it's a much safer bet when bisphosphonates are too risky. When you're counseling on this, a key point is to really stress good dental care because of that risk of osteonecrosis of the jaw.
So, where does calcitonin fit into all this? Think of it like the emergency response team. It works incredibly fast, we're talking 4 to 6 hours, to bring down dangerously high calcium levels. But, and this is a big but, its effect is super temporary. It's pretty much done after about 2 days.
That's why we call it a bridging therapy. It gives you that rapid control while you wait for the slower but much more durable guys like bisphosphonates to kick in.
Okay, let's boil all of this down into a few high-yield, absolutely critical takeaways that you can start using in your practice right away. If you've got a patient with severe, symptomatic hypercalcemia, this is the 1-2 punch you need for immediate control. Aggressive IV hydration plus calcitonin. It is the fastest way to get that serum calcium down, and you'll often see a big difference in just 6 to 12 hours.
So you see, it's a two-phase attack. Phase 1 is that immediate, rapid response with calcitonin and fluids. Phase 2 is all about establishing long-term control. And that means getting a long-acting agent like a bisphosphonate or denosumab on board, ideally within that first day, to get a durable effect that's going to last for weeks.
And this chart right here, it tells the whole story perfectly. Look at calcitonin. It gives you control for just a day or two. That's your bridge. Then look at pamidronate and zoledronic acid. A single dose can give you control for 3, 4, even 5 weeks. That's the foundation for sustained management.
So I want to leave you with one final thought, something you can take back to your pharmacy tomorrow. Think about all the things that can cause this: thiazide diuretics, lithium, way too much calcium and vitamin D, the list goes on. By just actively screening for these agents during every single medication review, you're not just managing a lab value, you're practicing real preventative care, and you're protecting your patients from serious harm. Thanks for watching.